We will continue the cardiac assessment for patients undergoing non-cardiac surgery. In the first lecture, we revised the clinical risk evaluation and the preoperative assessment tools that we have. In the second lecture last Friday, we took the general risk reduction strategies. Today, we are going to talk about the specific diseases for patients undergoing non-cardiac surgery. And next time we will finish the anesthesia and especially the patients undergoing renal transplantation, the preoperative risk assessment for them. What are the specific diseases that we have to cover for a patient entering non-cardiac surgery? They include coronary artery disease, chronic heart failure, valvular heart disease, and we will spend most of the time of the lecture in these three entities. And rapidly, we will go through the arrhythmias, the adult congenital, the pericardium, the pulmonary disease, the pericardial disease, the peripheral and cerebrovascular diseases, renal disease, obesity, diabetes, and cancer. So let's start with the important entity, the coronary artery disease. It is very important to us as a cardiologist to assess patients who have coronary artery disease and they are undergoing a non-cardiac surgery. First, a question: what is the risk of coronary artery disease patients undergoing non-cardiac surgery? The perioperative risk of cardiovascular complication for patients with established coronary artery disease is increased compared with patients who do not have coronary artery disease. And this risk depends on several factors. The first is the baseline cardiovascular risk, the type of surgery, the degree of urgency of the non-cardiac surgery, as we know that acute or emergency surgeries have higher risk of morbidity and mortality. Older patients, of course, have higher risk than younger patients. Patients with a recent ACS, of course, have higher risk than those with chronic coronary syndrome. And also the presence of comorbidities may influence the risk. This is from last lecture, the indications for stress imaging for patients undergoing non-cardiac surgery. We knew that it's class 1 to do stress imaging before a high-risk elective non-cardiac surgery in patients with poor functional capacity and a high likelihood of coronary artery disease or high clinical risk. Also, it should be considered class 2A before a high non-cardiac surgery in asymptomatic with poor functional capacity and they have history of previous PCI or CABG, even if they don't have any symptoms. But it's only class 2B before intermediate risk non-cardiac surgery when the patient have several clinical risk factors. Routine stress imaging, of course, it is not indicated. And the coronary angio, it is recommended to use the same indications for invasive coronary angio and revascularization preoperatively as in the non-surgical setting. The CT should be considered to rule out coronary artery disease in patients with suspected chronic coronary syndrome or a low-risk non-ST ACS, which means an unstable angina, in case of a low to intermediate likelihood of coronary artery disease. In patients undergoing elective surgical carotid endarterectomy, invasive coronary angiography is class 2B. Routine invasive coronary angiography, of course, is not recommended. So we will deal with coronary artery disease with the two entities of coronary artery disease, the chronic coronary syndromes and the acute coronary syndromes. The chronic coronary syndromes, the rationale for coronary revascularization before non-cardiac surgery is to prevent the perioperative myocardial ischemia, leading to acute myocardial infarction, hemodynamic instability, and arrhythmia. So the goal is you do coronary vascularization to reduce the complications perioperatively in patients suffering with chronic coronary syndromes. So do we have evidence about we should go routinely to revascularize all patients with chronic coronary syndrome? or we should choose certain patients to revascularize, or what? First, we have weak evidence in favor of routine revascularization in chronic coronary syndrome, which means that any patient with chronic coronary syndrome, you do angiography and you revascularize. This is a weak evidence. These are data from autopsy studies following fatal perioperative myocardial infarction, showed that more than 2/3 of the patients had significant left main or 3-vessel disease. Also, there is a retrospective registry based on the CASA study found that CABG reduced the risk of perioperative mortality and MI in patients undergoing major non-cardiac surgery, particularly if they had 3-vessel disease and a reduced left ventricular ejection fraction. So there was some benefit in patients with left main or 3-vessel disease or 3-vessel disease with reduced ejection fraction. However, this evidence comes from retrospective autopsy findings or retrospective registry that was not designed prospectively for this purpose. So it's a weak evidence. There is a study known as the Coronary Artery Revascularization Prophylaxis, the CARP trial. This trial recruited 510 patients with chronic coronary syndromes. They were randomized to either optimal medical therapy or coronary vascularization, surgical or percutaneous, before major vascular surgery. And in this trial, there was no difference in acute myocardial infarction after 30 days and mortality after 2.7 years. Of note, this study excluded patients with significant left main disease, while 1/3 of the patients in this trial had a 3-vessel disease. So this is the first randomized trial to address the problem of routine revascularization. However, it showed no difference in perioperative myocardial infarction or mortality after 2.7 years. This is a trial to check for routine PCI before carotid end arterectomy. It recruited 426 patients without evidence of coronary artery disease and scheduled for carotid end arterectomy. They were randomized to either routine coronary angio with provisional revascularization before carotid end arterectomy, or just to go for carotid end arterectomy without previous coronary angio. Again, there were no difference between the treatment groups in all-cause mortality, acute MI, and stroke at 30 days. A recent retrospective analysis on more than 4,000 patients undergoing total joint arthroplasty found that the risk of adverse cardiovascular events was increased in patients with coronary artery disease, regardless they were revascularized or not. However, in patients receiving coronary revascularization, the risk decreased as the interval between revascularization and the surgery was more than 2 years. So, to conclude the evidence we are having, we don't have, and there is a lack of evidence in support of routine prophylactic revascularization in chronic coronary syndrome, but this does not preclude a decision process based on individual risk-benefit assessment in patients with significant amount of ischemic myocardium, as in the case of left main disease and or with refractory symptoms, maybe 3-vessel disease also. يعني ايه؟ يعني الايفيدنس بيقول ان البروفيلاكتيك ريفاسكولايزيشن اي عيان عنده كرونيك كوروناري سيندروم وداخل يعمل جراحه ان انا اعمل له ريفاسكولايزيشن بروفيلاكتيك روتين، ده ما فيش ايفيدنس عليه وبالتالي جايد لاينز مش بتعمل له سبورت. ولكن لازم نعمل زي ديسيجن بروسيس على مالتي ديسيبلينري ابروتش، بالذات في العيانين اللي في الترايلز بان ليهم شويه ايفيدنس، اللي هم العيانين اللي عندهم ليفت مين ديزيز، العيانين اللي عندهم مالتي فيسل ديزيز، وكمان لو العيان عنده انجينا والانجينا دي ريفراكتوري، فالبيشنتس دول ممكن يستفيدوا من ريفاسكولايزيشن. طيب ده الالجوريثم بتاع الجايد لاينز اللي هنكفر فور acute coronary syndrome and chronic coronary syndrome. So let's start with chronic coronary syndrome. The first step is, as always, you should optimize the guideline-directed medical therapy. If you have, so you have a patient with chronic coronary syndrome, you adjust his guideline medical therapy, and you remember the perioperative bridging of antiplatelets from last lecture. Then you check the risk of the surgery. If it's a low risk surgery like eye surgery, you don't have any further screening. What if it's an intermediate risk? If it's an intermediate risk, you have to do clinical examination, ECG, biomarkers, and functional capacity. If there are symptoms, or if the ECG was abnormal, or if the patient, you cannot assess his functional capacity, or he has elevated biomarker, if any of this is true, you should do transthoracic echo and stress imaging. If the labs showed elevated troponin or there is a stress-induced ischemia, you should go with invasive coronary angiography, and then you do a multidisciplinary approach between the cardiologist, the surgeon, and the anesthesiologist. What if the surgery risk is a high risk one? Again, in this case, you will not wait for if the patient has symptoms or abnormal ECG, or you cannot assess the functional capacity, you will directly go for stress imaging with transthoracic echo. And if you have any of these, you will go again for invasive coronary angio and manage accordingly. So the summary of recommendation in patients with chronic coronary syndromes: if PCI is indicated before non-cardiac surgery, you should use, of course, the new generation drug-eluting stents over the bare metal stents and balloon angioplasty, the ones that you can stop the DAPT after 3 months or minimum of 1 month. Preoperative evaluation of patients with an indication for PCI by an expert team should be considered. If the patient is undergoing a high-risk elective, you should consider myocardial revascularization depending on the amount of ischemic myocardium, refractory symptoms, and finding at the coronary angiography, as in case of left main disease. So its recommendation is only class 2B because I have shown you that the evidence is not very strong. And they mentioned in particular the left main disease because the trials showed benefit in left main disease. Routine revascularization before low and intermediate risk non-cardiac surgery in patients with chronic coronary syndrome is not recommended. What about the acute coronary syndrome? The acute coronary syndrome is much more simple than the chronic coronary syndrome. Of course, you should optimize the recommended medical therapy, and you should follow the diagnostic and therapeutic approach according to the appropriate guidelines, whether it's STEMI or non-ST elevation ACS, regardless of the surgery, because the ACS is a life-threatening condition. So, in patients with acute coronary syndrome, if the non-cardiac surgery can be safely postponed at least 3 months, it is recommended that patients with ACS being scheduled for non-cardiac surgery undergo diagnostic and therapeutic interventions as recommended by the guidelines. In the unlikely combination, if you have this rare situation when there is a life-threatening condition requiring an urgent non-cardiac surgery, and at the same time a non-ST elevation ACS with an indication for revascularization, the priorities for surgery versus the non-STEMI should go case by case, considered by the expert team. So the rule is you defer the surgery, but if this unlikely combination of a life-threatening clinical condition needing surgery and non-ST elevation at the same time, you could check it case by case. So to understand better the recommendations, let's take some cases to help us with this. This is a 50-year-old male. He works as a football trainer. He has cardiovascular risk factors are current smoking and elevated cholesterol level. 3 years ago, he had PCI for his OM and ramus, and it was on an ST elevation ACS. For now, there are no current symptoms. His blood pressure is a bit high, needs more control with good functional capacity. His medications are clopidogrel as he has aspirin intolerance, atorvastatin, and beta blocker. He is planned to do arthroscopic partial right meniscectomy due to chronic meniscal degeneration. So what is the most appropriate management for this patient? Should we test for stress imaging? Does he have a silent ischemia? Should we do invasive coronary angio to exclude disease progression, target versus the remote vessels? Should we do no further screening and proceed to surgery directly? So, as we always do, we go to the table to determine the risk of the surgery. This is an arthroscopic orthopedic surgery. It is a minor orthopedic surgery. It is a low surgical risk, less than 1%. Again, we go to the first algorithm we had. It is not an emergency or urgent, and it is not a time sensitive. It is a totally elective non-cardiac surgery. So we have to take accurate history. We do good clinical examination. We do the standard labs and advise on stopping the smoking and give him the optimized guideline-directed medical therapy before any decision. After this, this is a patient with established cardiovascular disease. He had PCI 3 years ago, but his surgery is a low risk. So according to this, no further investigation should be done. So it's better for him to stop smoking more than 4 weeks before the non-cardiac surgery. It's class 1. And if there is time to optimize the guideline-directed medical therapy and cardiovascular risk factors, for example, this patient has uncontrolled hypertension, it's better to do this. And from the algorithm we just discussed, this patient is a chronic coronary syndrome. Its first step is to optimize. If he is a low-risk non-cardiac surgery, you don't need any further testing. So you don't need stress imaging. You don't need invasive coronary angiography, and you don't need biomarkers or echo or anything for this patient. If you remember from the recommendations for the stress imaging, they had the class 1 was for the high-risk surgery for certain patients, and the class 2A was for the intermediate risk surgery, but for the low-risk surgery, it was class 3. Let's take another case of a 78-year-old female, retired English teacher. She has cardiovascular risk factors in the form of diabetes on insulin. She has chronic kidney disease with a GFR of 43. She had a CABG due to stable coronary artery disease in January 2022, which means 9 months before the index surgery that we need to do for her. She has history of atrial fibrillation. She has reduced systolic LV function, 52, or a borderline fair ejection fraction. She has dyspnea NIHA class 2. Functional capacity could not be assessed, as you can think of a post-CABG patient, 78-year-old female. She is on novel oral anticoagulants for her atrial fibrillation, and this makes a single antithrombotic. For stable coronary artery disease, it has to be a NOAC. She has a statin intolerance for her age, so she is on ezetimibe. She on a small dose of a diuretic, on beta blocker and angiotensin 1 receptor blocker. She is scheduled 9 months after the CABG for lumbar decompression surgery for relief of symptoms of nerve compression without functional impairment. So what is the most appropriate management? The first step is to check for the risk of the surgery. So regarding neurological surgeries, hip and spine, it's an intermediate risk surgery. So for this patient, an intermediate risk non-cardiac surgery, you should do an ECG and biomarkers, and you should assess her functional capacity. Again, we mentioned it cannot be assessed for her age. So what if when we do the biomarkers, the troponin and the BNP, the troponin value for this patient was pathological, was actually 3 times higher than the upper limit of normal. So should we postpone and reschedule after 1 month? Should we prescribe high-dose statins and proceed to surgery? Should we postpone surgery if feasible and start the diagnostic pathway for ACS patient? So we have an elevation of the troponin which may qualify for a non-ST ACS. So this patient should follow the pathway for non-ST elevation ACS. She should do a follow-up troponin. She should do echo. We should check if she needs to undergo coronary angiography again, and then we postpone the surgery and do it as soon as possible after. So the answer is clear for ACS patients. You should postpone the surgery and start the diagnostic pathway for ACS patient. If she proved to be ACS and you did PCI, you act accordingly. If she proved that this elevation is just a mild, her baseline elevation of troponin, you should then send her for surgery. Let's take a third case of a 62-year-old female nurse. She has elevated cholesterol, she's obese, with a body mass index of 32. She is on regular hemodialysis. She did PCI with a drug-eluting stent to her RCA and diagonal branch due to non-STEMI on August 2022. She has reduced systolic function, 42%. She has no symptoms with good functional capacity. She is on aspirin, prasugrel, statins, beta blocker, and angiotensin receptor blockers. And she is scheduled for a total hip arthroplasty due to arthritis, pain with mild functional impairment. Should we proceed to surgery without any further delay? Should we measure biomarkers twice before surgery to rule out recurrent ischemia? Should we defer the surgery until the antithrombotic medication course have been completed? She did a PCI on August and the surgery scheduled on October. So again, what is the risk of this patient? The risk is intermediate for the hip surgery. For the intermediate, you should do ECG biomarkers and assess the functional capacity. The functional capacity was good, so you should do ECG and biomarkers. And this algorithm from the last lecture, if you have a patient on dual antiplatelet therapy, the first question is, does he have a high bleeding risk or not? If the patient has high bleeding risk, you should go for the next step. So does our patient have a high bleeding risk or not? Actually, the patient has a high bleeding risk because she is on regular hemodialysis, and this is a very important risk factor for bleeding. Does the patient have a high thrombotic risk or not? Actually, she did PCI, and let's go back. The intervention was due to non-STEMI, so she had an ACS less than 3 months ago. So she also has a high thrombotic risk. So the patient is having a high bleeding risk due to her hemodialysis. She is having a high thrombotic risk. And the next step is you ask yourself, is it a time-sensitive non-cardiac surgery or not? The answer is it's not a time-sensitive non-cardiac surgery. Why? Because it's a hip replacement. So in this case, you should defer the non-cardiac surgery until the patient continue her DAPT. So this is the best choice, to defer the surgery until antithrombotic course has been completed. So let's go to the next disease. We have to cover the chronic heart failure. What is the risk of patients of heart failure undergoing non-cardiac surgery? Heart failure is an established risk factor for post-operative mortality across a broad range of surgical specialties. The risk of adverse post-operative events is associated with heart failure depends on multiple factors. It depends whether the LV function, the systolic LV function, is preserved or not. It depends whether the patient is compensated or not. And finally, it depends if the patient is having any other symptoms. Regarding the pre and post-operative management, you should put the patient on optimal guideline-directed medical therapy, the 4 pillars of heart failure, before scheduled non-cardiac surgery is recommended. Special attention should be given to the fluid balance, since, as we all know, the surgeons like the fluids, and the patient will be subjected to high volume infusion in the perioperative period. Invasive monitoring of the arterial pressure, aiming to obtain oximetric and metabolic parameters during non-cardiac surgery, is needed for intermediate to high risk non-cardiac surgery with heart failure. You should do invasive arterial blood pressure monitoring. And we might make use of the more invasive tools, such as the right heart cath, the TEE, on individual patient level according to the needs. When we discuss the patients with chronic heart failure, we should give special attention to the patients with hypertrophic obstructive cardiomyopathy, the HOOCAM patients. These patients who have LV outflow tract obstruction have an increased risk of complications during non-cardiac surgery and require attention. It is recommended to perform a transthoracic echo to determine the extent of hypertrophy, the degree of obstruction, and the diastolic function before surgery. You should avoid the prolonged preoperative fasting and dehydration, because these patients are very volume dependent, to maintain the stroke volume and reduce the risk of increased obstruction. Furthermore, it is important to avoid the vasodilating anesthetic agents and maintain neutral fluid balance during the perioperative period for the same reason, which is that the patients are volume sensitive. The heart rate should be kept low, between 60 to 65 beats per minute, and AF should be avoided. Medication used to treat the LV outflow tract obstruction should remain on board during the non-cardiac surgery, like, for example, the beta blockers. So the recommendations for the patients with chronic heart failure undergoing non-cardiac surgery. The first one, in patients with suspected or known heart failure scheduled for a high-risk non-cardiac surgery, it is recommended to evaluate the LV function with echo, to measure the biomarkers in NT-proBNP or proBNP levels, unless it has been recently performed. It is recommended in these patients with heart failure undergoing any non-cardiac surgery to receive the optimal guideline-directed medical therapy. In patients with heart failure undergoing non-cardiac surgery, it is recommended to regularly assess the volume status and signs of organ perfusion. This is not in our patients, but in Aswan, they have a lot of some VAD patients. You should have a multidisciplinary team, including VAD specialists, for perioperative management of patients with heart failure receiving mechanical or circulatory support.